Okay, good evening, everybody. Like Sue said, my name's Sarah Milnes, and I'm a lecturer at the University of Leicester. And I'm really passionate about mental health and birth trauma. And for the last few years, I've been looking into empathy. So I'm just going to take you through some of the things that I've thought about and considered along the way. So what is empathy? So empathy is putting yourself in somebody's shoes, walking a day in their life, understanding their thoughts, feelings, perceptions about the world. And that's different for everybody and it's different for different people. Sometimes it's really easy in maternity to compartmentalize people and treat people due to their illness or certain characteristics about them, so medical characteristics. But we need to kind of step away from that and see the world through their eyes and actually how can we improve care for them as an individual. So there's this thing called parity of esteem. It's something you might be familiar with. It's something that you might not be familiar with. And this is valuing physical and mental health equally. So what a lot of the research suggests that if you take nursing, for example, if you are a physically trained nurse or if you're a mental health trained nurse, you can't recognise complications across the disciplines. So actually, people who are under the care of somebody who is a single reg qualified are more likely to die. They're more likely to have complications, more likely to have problems. So one of the things that we're trying to do at the minute is to ensure that people have an appreciation of mental health and physical health. And that's something that we teach at the university. So we have a dedicated perinatal mental health module and we run it through all of our modules. So we're not just looking at the physical aspects of pregnancy and maternity, but we're thinking about that holistic care. So we're having this holistic approach where we're looking at the social side, the spiritual side, the physical side, the psychological aspects of that individual person. And we're trying to treat the person and not the illness. So like I said, pregnancy impacts individuals very differently. And so it's about listening to them, talking to them, finding out how we can help them as an individual and understand, why, how and what they're experiencing. So I'm just going to take you through a pregnancy journey. Now, as a midwife, it's quite easy to get very task orientated and task focused. And sometimes it's good to step back and look at the care we're giving through the eyes of somebody else. Because we are au fait with this. It's our bread and butter. It's our everyday. We understand all of these things. But actually, the people that come into the service and the people that we care for, this might be the first time they've had sustained contact with the National Health Service. They may have never been to a hospital before. So even just like sights, smells, noises, they're very familiar to us. They're not scary to us, but they can be scary to people that are coming into the system. So I just thought we'll take a walk through, and it's always good, like Sue said, to reflect and to remind yourself of those things that these people might be experiencing. So the first trimester, lots of people are happy that they're pregnant, they're really excited, full of happiness, joyful, something that might have planned. But some people, that might not have been the right time in their life to find out that they were having a baby. So some people actually come into the services feeling very scared. They're worrying. They have a lot of anticipation because they might not feel ready to be parents. So sometimes greeting people with congratulations is not always the thing that everybody wants to hear. So again, it's looking at those cues to find out how families feel about this situation. How they feel might be dependent on whether the pregnancy was planned. They might be thinking, well, now my life's going to be really restricted because of certain things that I can and can't do. I'm now going to have a child to look after for the rest of my life. So they feel like they've lost that independence because I tell you, before I had children, I could pop to the shop. And then as soon as I had children, I would probably have to feed them, change them, feed them again, maybe change them again. Then they'd be sick. And you've got to tackle the car seat, get in the car, and then 45 minutes later, you might be at the shop. So nothing is straightforward once you've had children. Children are expensive. It's costs a lot of money to raise a baby. And not everybody's in that situation, particularly the cost of living nowadays. And also, with two-parent working families nowadays, two people have to work to keep a house afloat. So someone suddenly say, oh, I'm going to have to go on maternity leave, I'm going to have to take a pay cut, or I'm going to have to, maybe go part-time or afford childcare. These are all things that scare people. And so they're already feeling this anticipation. They might not have any family support, because what happens? People go off to university and then they meet somebody at university and then they stay there, and then their parents are 200 miles away, and we don't have these villages anymore where we know everybody and we help each other out. And they might be thinking, I've got nobody around me to help and support me through pregnancy, or support me when I have a newborn or a toddler. There might be cultural pressures or expectations of things that they should do in their pregnancy that they might not necessarily agree with, but feel this cultural obligation to do it for their family. So again, that's another consideration. And I think this is one, certainly when I was a midwife and I was a student and I worked on community, I think women that are experiencing pregnancy following a loss, I don't think we put enough emphasis on it, particularly at the booking appointment, because we just say, oh, what number of pregnancies is this? And they'll say, oh, I've had a miscarriage. I had a miscarriage at 5 weeks, 6 weeks. And we just write it down. And I think we need to maybe just have a think about how that's going to make that person feel coming into pregnancy after following a loss of a baby. So again, in the first trimester, women might fear miscarriage, and this can give them huge anxiety, particularly, like I said, they've lost a baby before. A lot of women get an implantation bleed around 5 or 6 weeks, end up having to go for a scan. And again, they say that sometimes it's just a conveyor belt. They just go through and they get a scan to reassure them. But actually think about how that person's feeling. They're bleeding. Bleeding is the first sign of miscarriage. They're going to think the worst, aren't they? So again, it's just thinking about how those people are going to feel. And families often delay announcing a pregnancy until after the 12-week scan, because in people's eyes, 12 weeks is like the magic time where they've had the scan and the baby becomes real because they can see it, because before they've not really felt anything, not felt any movement. So prior to that, they often keep it a secret from friends, families, colleagues, and then they might be struggling with things like morning sickness or extreme tiredness. And that can be really, really tricky if you're trying to hide that from people. And then they go to the booking appointment. So the booking appointment's really exciting because they're going to meet the midwife for the first time, and they're going to get themselves into the system, and it finally starts to become real that they're actually pregnant. And most women will book around 8 weeks of pregnancy, so quite early on, but also quite far along from when they conceive this baby. And straight away we say, okay, you can't eat this, you can't have that, you can't drink that. You should have had folic acid for 2 to 3 months prior to conception, but they may not have been on that, they may not have known. We should say, we always say alcohol and smoking should be avoided when trying to conceive a baby because there's a risk of miscarriage. You should have a really good diet prior to conceiving your baby because of the impact that can have on the pregnancy. But so many pregnancies are unplanned. So if we start giving out this advice, it can give people a lot of guilt and anxiety. And we know that feelings of anxiety in pregnancy is not good for the pregnancy and not good for the baby. And I can tell you now, most people I've booked have probably conceived their baby in a sea of alcohol. So there is a lot of women out there that straight away feel very, very anxious. And it's about understanding and empathizing with that anxiety and try to put it into kind of probably going to be okay, but this is the advice that we have to give. The next thing we do is we offer people screening tests. Now, again, we're quite au fait with screening tests as midwives. We know quite a lot about them. We practice evidence-based practice, so we're constantly reading research about screening tests. But for many women and families, if this is their first pregnancy, they don't really know anything about pregnancy or childbirth, because gone are the days where you'd probably support your sister having a home birth, or you'd witness birth in the community. Now birth is this thing that's shut away in a hospital, and unless you've experienced it, you don't really know much about it. And these women have a 1 hour appointment where they're bombarded with so much information that they're extremely overwhelmed. And then we ask them really, really important questions about screening tests. And when these screening tests come back, the results of which may lead to further testing, which can cause miscarriage. And also, what we're testing for is chromosomal anomalies in the baby. So again, this is a massive decision to make with very little time to think about it, and really very little information. And we know that studies say that women who are given too much information at once, they can't make an informed choice. They kind of just get swept along and go with what they think is right, or what you think is right, which is even worse. So it's about ensuring that women have the right information and they have the right amount of time to think about it. I mean, if we were doing a research study, they'd haul us over the coals with ethics if we didn't give people long enough to think about and make an informed decision. So again, we need to be thinking about this with the women that we're caring for. And then women that have language barriers or learning needs, they're going to need even more support to make an informed choice and an informed decision, because it's going to be harder for them to understand. So then it comes to the second trimester, and women and families get really excited about the 20-week scan, and we even see it referred to on social media, don't we, as it's the gender scan, it's a sex scan. I'm going to find out if we're having a male or a female infant. And they fail to recognise, and I think, you know, sometimes we perhaps don't emphasise enough that scan is actually to look for anomalies. And if you find an anomaly at 20 weeks, that's a huge decision to make about where you're going to go with that information, because there's fear of the unknown. Often we see anomalies, but we don't actually know how that's going to pan out in that child or that family's life. And sometimes parents are left with a really difficult decision of whether or not to terminate a pregnancy. And again, that is a really, really difficult decision to make and a difficult thing to do. And I don't know if we put enough emphasis and support on those women making those decisions. So the third trimester, I've got a brick wall here, because you often find that women will think about the pregnancy and they'll think about getting up to labour, and that's it. They don't think about anything more. They kind of hit a brick wall and they can't get themselves past it. And so towards the end of pregnancy, people start to feel uncomfortable. They might be suffering with SPD, so symphysis pubis dysfunction, which is quite debilitating, really. And I don't think, again, we put enough emphasis on these. Things like symphysis pubis dysfunction and morning sickness and tiredness, they're referred to as minor disorders of pregnancy, when actually they can be really, really debilitating to women. They might have to spend time in hospital, away from their families, away from their children. You know, that's a very lonely place to be if you're suffering with these disorders. They might be really frustrated that the rings don't fit. I remember I got really annoyed that I couldn't tie my own shoelaces. That really, really annoyed me towards the end of pregnancy. They start to become really anxious about labour and birth because, again, you know, there's a massive lack of antenatal education nowadays. It used to be that community midwives would provide antenatal classes for all of their women. They'd all have 5 or 6 sessions, and they'd almost feeling like they had a little bit of knowledge about what was going to happen to them, regardless of what path they ended up taking. And I think now there is lack of information. And like I said, a lot of women have never been into hospital. They don't know what to experience. It is quite a scary place, first time you ever step in there. And everything you see on TV is scary. So, you know, women will labour really fast on TV. They'll go from 0 to 60. And that's how women think they're going to labour. And actually, they'll come in and they'll have a multi-toss, or they'll be 2 centimetres. And then, you know, what do we kind of say to them? We say, oh, you're only 2 centimetres. I mean, how awful is that to hear? I've had all this pain. I'm really struggling and I'm only 2 centimetres. And I always say to my children, never say just or only. There is always a positive. So even if you just go in and say, you know what, actually, you've done a lot to get to this stage. You're doing really well. You're coping really well. But at this moment in time, we don't know if it's going to continue or if it's going to settle down. So we just need to look after you for a bit and just make sure you feel better and put them in a nice environment where they're going to want to labour. Again, it's just putting yourself in their shoes. They fear the pain because, let's face it, nobody's experienced that pain before. They don't know how they're going to cope with it or deal with it. And they fear that lack of control. And actually, you see it, don't you? Women come into hospital, and the first thing they do is they sit on the bed in the center of the room, and they just kind of say, oh, you do what you think's best. They lose that control. And I think once you lose that control of anything, of any aspect of your life, the world becomes a very scary place. And I think that can be quite scary for women. And towards the end of pregnancy, women always get a nesting instinct, don't they? I think I was painting the ceiling at 36 weeks pregnant, and I was told off by my husband. But this is to try and regain a little bit of a sense of control, because it's something that they want to do and something that they feel the need to do. At this stage, both parents start to think, are we going to be any good at it? Actually, I'm thinking back to my childhood. What did I learn? What was my upbringing like? Can I do it? It's such a massive responsibility. And that's quite overwhelming for people to have that suddenly hit them. So unfortunately, what we're seeing is a lot of women are experiencing what we call birth trauma. The statistics are 1 in 4. I think maybe since COVID, it might even be 1 in 3 women now experience birth trauma. And it's not always a dramatic event. So we used to consider birth trauma as, oh, they've had a horrendous instrumental birth, a huge postpartum hemorrhage. That's a really physically traumatic thing. But actually, a lot of women and partners, dads, experience trauma because they felt that they had lack of control. They felt that they weren't listened to. They didn't have enough information. And the care that they received wasn't compassionate. And actually, multigravid women, so women that have had babies before, are 5 times more likely to fear birth in a subsequent pregnancy. And it's not just about subsequent pregnancies that we need to be concerned about. Actually, some of these women, it puts them off things like smear tests. It puts them off going to postnatal classes. They then end up with anxiety and depression, which has a huge impact on their attachment with their child. And we know the first 1001 days from conception to about 2 years old are the most important in a baby's life, particularly when the brain is developing. That's the biggest growth of brain development. And if you don't have a great attachment with your child, that can be hugely impacted. And then families look back and they feel guilty about that. So it's about supporting them all the way through. So families want choice. Choice is a big thing. I mean, it's fine saying that women have got this choice, but they only know what they know. And it's actually a really difficult thing to navigate the maternity services. I educate students about maternity services. I know everything across the childbirth continuum, but I can't tell you everything that's out there. And I think sometimes they have a faith in the system. So they almost go with what we think. And also when women are in pain, they're very susceptible to persuasive communication. So what might seem really kind as saying, oh, would you like an epidural? Or would you like pain relief? If they were adamant that they did not want that, and then you're doing the really kind thing, but actually you're saying almost this is what we recommend without saying it. Sometimes women will say yes, and then actually they turn around later and go, that's not what I wanted. But I went with it because I thought that was what was best. So they want control. And again, it's about giving them that locus of control. So just supporting them, find out who they are, what they want, what their desires are. And the other thing they want is compassionate care. Now, I know that everybody is really, really burnt out, and I go in and I see my ex-colleagues and I see how burnt out people are in the NHS, and it's really sad. But compassion actually, and empathy, it doesn't have to be a huge time-consuming thing. It could just be what we call a fleet of compassion. So it could be actually sitting down next to somebody, giving them eye contact, active listening. If you're asking questions as part of the booking appointment, I know everything's online now and people have to fill out things and you've not got a lot of time, but just look at them and just show them that you're listening. Put your hand on their arm, just really little things that can really make somebody's day and let them know that you're listening to what they're saying. And that can be really, really important to people. So this is my little boy. This is George. He's now 10, so he's no longer this small. he's just as cheeky, but he's no longer this small. So I think it really hit me about empathy when I had George. He was 3 months old. And on Christmas Day in 2013, I thought I was getting a day off from the hospital, but I ended up going in because he was admitted to Leicester Royal Infirmary with bronchiolitis and dehydration. And it was horrible. They took him in and they put this NG tube down him. And I've put NG tubes in babies. I've fed babies through NG tubes. We send babies down for antibiotics. We do lots of things and very aware of the care that we can give to newborn babies. But when they held him down and they put that NG tube in, I cried and I suddenly felt very sick and it was horrible. And it suddenly made me realise that all the care that we provide, it's our everyday, but it's not theirs. And actually, this is one of the most important times in their life, and this baby is the most precious thing to them. And so we have to be thinking about how they are thinking and how they are feeling. And that's why I always say to the students when they go to the neonatal unit, go to the neonatal unit, spend some time there, see what it's like, then you'll know a little bit about what these parents are experiencing. And I think that's a really important lesson to learn, particularly for students. So I have this case study. This is from the Embrace report, and it's basically about this lady who was really anxious in her pregnancy because she'd experienced a previous pregnancy loss. So all the way through her pregnancy, midwives were very caring, very concerned about her. And then as soon as she had the baby, they thought, well, the baby's here now, so actually she should be okay because the baby's here and everything's fine, worked out well. But actually, her mental health spiraled after that. And they tried to get a scene and they couldn't get a scene quick enough. And actually, she took her own life. And I think what I'm trying to say is don't assume. Don't assume you know what somebody's thinking and feeling, and don't assume that people feel better because whatever the traumatic thing that was happening in their life has now gone away, because actually it still continues. And death by suicide is still really, really high amongst women. And I think with the level of birth trauma that we're seeing, this is something to take away, just to be mindful. So in terms of teaching empathy, and you can teach empathy, I always thought that empathy was something that you were born with, but actually you can teach it. So some of the things that we do within the University of Leicester is during the induction week, one of the first things we do to the students when they arrive at the university is we put them in our clinical skills bay and we put them in beds. And then we get them to wash each other's hands. And we get them to feed each other, and we get them to change the sheets under them so they know how vulnerable it feels to be a patient. And by the end of the day, what we find is instead of standing over people and saying what they're going to do, they sit down next to them and they give them eye contact. And we think that's really important. We also do a lot of interprofessional education right from day one. And we do in induction week again, a patient's journey through the NHS, because I think if you use real people that have been through the system and people that have had certain conditions, it makes the condition real and it makes you able to relate to it more and understand how people have to deal with that on a day-to-day basis. You're just seeing a snapshot of their life, and some people have to live with these conditions long term. One of the other things we do is we encourage our students to do case loading right from year one. So our first year students pick up 3 or recruit 3 case loading women, and they go through the service with them to all of their appointments as a professional friend. And what they do is they go and see what it's like as a woman in Leicester to go through the maternity services. And that straight away starts to give them empathy, because they have to wait in scan click for an hour because they're running late, or they can't get hold of somebody, or they see some of the fragmented services that some people have to go to and how much of a challenge that is. And as they progress throughout the years, their responsibility gets more and more. So even in first year, they're on call for their birth, but again, just to go along and hold their hand as another way of supporting them. And they really, really value it. They love case loading. We use service users in a lot of our teaching. And again, it's getting their perspective. And the other thing we've introduced this year is we've been running antenatal classes and infant feeding classes at the university, and the students are actively participating in that as well. So they can they can see women's worries and fears and anxieties, and they can make a positive impact on that for them. So that is the end of my presentation. I've put some references on there should anybody want to go and look any further. And thank you very much, Sue, for having me.